Hey everybody, welcome back to the ECG of the day. My name is Reed, and if you would like to follow along with today's ECG, you can download it down from the description below. It is linked. And don't forget to like this video and subscribe to the channel if you enjoy this content. So let's jump into it. So the first thing I like to do is I like to look at the forest, and the trees of the forest are my QRS complexes. And so I see maybe here, if I look down at lead 2, I've got a regular QRS complex that seems to stay that way throughout the entirety of the rhythm. You can notice that my QRS complex does seem to be wide. It seems like the takeoff is right around there, terminates to it. Appears to be a wide complex rhythm, but it's regular at a rate of roughly 300, not 300, at 100 beats per minute, right? It's about three big boxes from each other, right? So we've got a tachycardia here, regular complex tachycardia. It appears, if I just look at it, that there are what appears to be some P waves before my QRSs. Let's take a look at those P waves. Those P waves, if I look up here in lead 1, they're upright in lead 1. If you look down here in AVF, they appear to be upright, maybe isoelectric in AVF. So it tells me that they are going down and to the left to an extent, which is typical of a sinus rhythm. So we can call this a sinus rhythm or a sinus tachycardia. Right. Next thing in my conduction system is my PR interval. Remember, my PR interval is representing my AV node function as that P is getting conducted to the QRS complex. And so I find a lead that's got a nice sharp P wave, and I think V1 is probably, as I scan through, probably my best bet. And so take the start of the P wave to the start of the QRS complex, and I notice that my PR interval is in between 120 to 200 milliseconds, or 3 to 5 small boxes. And if you notice that it stays that way the entire time, this is my arrows of my P's conducted to my QRS. So a PR interval is within normal limits, and it stays that way the entire time, and every P conducts to a QRS. Tells me my AV node is behaving. And so now I'm going to go to my QRS complex itself. We said that it was wide, and if I come down here and measure the width that we had gone, I would say that's probably 4 small boxes. And so 4 small boxes would mean that my QRS duration is 160 milliseconds, which is long. That's too long. 120 is what we like to see. So when I see a wide QRS, my first thought is, well, okay, where's this QRS coming from? We said this was a sinus rhythm. We said that we have an appropriate AV nodal function. So this node, the AV node, is capturing that signal and sending it down to the ventricle. So why is it conducting wide? So I always think of bundle branch blocks as a cause of wide complex rhythms that are being conducted from the AV node. And so I look up here in lead V1 and I look for a right bundle branch block morphology. What do I see? I see an R, S, R prime morphology in V1. And that R prime is what is telling us that we have late forces heading towards the right ventricle, right? And that would only happen if the right bundle branch was blocked. You can also see in the lateral leads 1, leads AVL, we've got these slurred S waves. See those slurred S waves? Well, these are, remember, 1 and AVL are the lateral leads. So if you have late forces that are having to depolarize into the right ventricle from slow cell-to-cell gap junctions, you're going to see a slurry S wave, right? So we got these slurry S waves in those leads. And so that's pretty characteristic and diagnostic together of a right bundle branch block, right? Let's measure our QRS axis to make sure there's no other conduction disturbances other than the right bundle branch block. We've got a QRS that is isoelectric in lead 1, but it is positive in AVF. And so what does that mean? Isoelectric means that it's going to be perpendicular to that lead. So if lead 1 is this way, then we have a QRS axis that is perpendicular to lead 1, but it's positive in AVF, so it's going straight down towards AVF. So we've got it at axis of positive 90 degrees, right on the upper limit of normal. A little bit of just almost right axis deviation, which we can sometimes see that in a right bundle branch block. Okay, Let's take a look at our QT interval. Sometimes I like to just eyeball my QT interval. We can find a QRS complex with a good, maybe V4 has got a nice QT that we can see. So I take my R wave from each, I draw a line in between the two, and at the midway point, you should see my T wave terminated by then, and I would say that seems to be the case. So just by eyeballing it, my QT looks okay. Remember, QTs are rate related, they change with rate. So that's why we have to look at it with the interval in mind. And so now my last step is to look for pathological Q waves or ST changes, which talks to me about previous myocardial infarctions and current. So I look through my anatomical leads and I notice something. I'm going through my precordial leads here, and I look in V2 and I see V2 has a little bit of, here's my baseline, we've got some ST depression. ST depression in V2. And so ST depression makes me think of ischemia. And so I look around and I'm like, well, where is this, is there widespread ischemia? But I look over in the inferior leads, really more specifically lead 3 and lead AVF. If I zoom in on those leads, you can see that I've got, first of all, I've got these deep Q waves in these leads. I've got some Q waves in these leads, which tells me that there could be some previous myocardial infarction. But I've also got ST segment elevations. There's my baseline, there's my ST segment. There's my baseline, ST segment. And so the morphology of this, where we have some Q waves developing, tells me that we probably have some of this inferior wall ischemia or infarction that's already starting to complete. So first off, we have ST elevation in leads 3 and AVF with some pathological Q waves. Okay, remember pathological Q waves are negative deflections that start the QRS, and that tells me that the region that's being supplied or measured by those leads is having a hard time conducting in that direction, which tells me about already infarcted tissue. So when I see inferior ST elevation, usually I look for reciprocal depression, ST depression. You can see a little bit here in AVL. You see, here's my baseline. Here's a little bit of reciprocal depression. Same thing in lead 1. You can get some reciprocal depression. Here's my baseline ST. So a little bit of reciprocal depression, ST depression in 1 in AVL. That's reciprocal. But I would say that this V2 ST depression is actually evidence of posterior involvement, right? Because we don't have leads on the back of the heart, but we have leads on the front that would change in an opposite fashion. So that's what V2 is, especially whenever you have an inferior MI. And so those are the major ischemic findings on this. And so, let's put this ECG together. So first thing we're going to call this is a sinus tachycardia at 100 beats per minute. We have a right bundle branch block, and we have ST elevation in leads 3 in AVF. So we have inferior ST segment elevation with some development of pathological Q waves. We have reciprocal changes with ST depression in leads 1 in AVL. And we have some evidence of posterior involvement with ST depression here in V2. And so this patient was urgently taken to the cath lab. They were actually found to have an occlusion of the first obtuse marginal, which is actually a branch, distal branch of the left circumflex. And this branch can kind of, the left circumflex can wrap around the heart posteriorly and also extend inferiorly, which is likely why we see some of that inferior and posterior involvement. So I hope this helps. Hope this is a good example of an inferior MI that's got a little bit of a variation, right? And so yeah, if you have any questions, put them in the comments. And if not, thank you so much for watching. Have a great rest of your day. See you on the next video.